Morning, everyone. This is David Hurl. I'm chair of the Education Committee of the Minneapolis Heart Institute Foundation. I'd like to welcome everyone here today for the beginning of our 2022-2023 season. The committee, along with Maya and John, Jan, have all been working hard to put together a great season for everyone. This year, we're going to continue our hybrid model. We'll have a wide variety of speakers who are here from the foundation, of course, nationally and internationally. I think we have an exciting slate picked for the year, and you're going to enjoy it very much. In addition, our hybrid model online, we also have that in the room. This year, we have no restrictions in terms of the number of people that can be with us, and we're very happy to see such a robust crowd today. We'd like to encourage people that are here on campus to attend in the room. We think that really helps in terms of the robust conversation that comes out of our grand rounds. And in addition, it's very important that we support our sponsors, because without our sponsors, this wouldn't occur today. In fact, speaking of our sponsors, I want to specifically thank Janssen Pulmonary Hypertension for being here today, and Novartis Cardiology. So thanks very much. We look forward to seeing you every week throughout the season. So to introduce our speaker today, Dr. Beckler.
Thanks, Dr. Hurl. So I have the distinct pleasure of introducing she should be a doctor, but Commissioner Jan Malcolm, who has been both a friend and colleague to myself. Commissioner Malcolm serves as Commissioner of the Department of Health for the state of Minnesota, where she's tasked with keeping the health of all Minnesotans as superior as possible. That includes our protection, maintenance, and health of our Minnesotans. Prior to being appointed commissioner, she served as adjunct faculty at the School of Public Health, where she was co-director of a national research and leadership development program funded by Robert Wood Johnson Foundation. Prior to that, she served as CEO of the Courage Center, and then when it merged with Alina, she became president of the Courage Kenny Foundation, and finally she served as Vice President of Public Affairs and Philanthropy for Alina. For those of you who don't know, she is the only Commissioner of Public Health that has served in 3 different administrations, first dating back. Good morning, Commissioner Malcolm. I was just sharing how you're the only commissioner that has served for 3 different administrations with Governor Ventura and then Governor Dayton, and now here with Governor Walz. For many, she has been reflected upon lovingly as sort of our Dr. Fauci of Minnesota. And I think many of us felt very comforted with her 2 p.m. news briefings for months and months in the beginning of the pandemic. I can't say what an honor it's been to have worked for her as assistant commissioner under the Walz administration, and also at her time here at Alina. So with that, we're thrilled to have you kick off our season here of Grand Rounds. Thanks, Commissioner.
Thank you, Courtney, Dr. Jordan Beckler. It's wonderful to see you. Thank you, Dr. Hurl. I'm really honored to be joining you for this series and kicking it off for this season. I appreciate the flexibility of the hybrid forum this morning. As fate would have it, it was my turn to get COVID. So I am now in isolation, my cat and I. And I apologize in advance if I'm a little under the weather today and have to stop for coughing or whatever. So that's kind of ironic, I think. But thanks to vaccination, I'm counting on this being a mild course. And like many people of my age, I'm actually quite a bit more worried about long COVID than the acute phase of the disease, thanks to all the advances in care that we've seen. So I do want to make this really informal today and more of a discussion. I do hope that you will have some questions and some reflections of your own. I have just some notes, some thoughts on the last couple of years, and what really stands out, I think, to me from a how can we do better perspective, as not only as healthcare delivery, but the larger health enterprise, most certainly including public health. What can we in public health do better? And what can we do better in even closer collaboration going forward? Because there are profound lessons, I think, to be learned, and challenges ahead that make it just absolutely imperative that we do really seriously have a time of reflection and evaluation to figure out what we should take away from this, and how we can redouble our efforts to be better prepared for the next health emergencies, because there will be more. And how we can apply some of those lessons to just improving the way that we serve our patients and communities every day. It's really it's really hard, I think, to find words that don't feel trite or just terribly overused to describe what this last 2.5 now years have meant to us as a society, as a profession, as individuals. A few words do come to mind, and I'll talk about a few of them. First, just the devastation in health terms and economic terms and beyond. It's just hard to really summon up enough words to describe just the sheer toll that this has taken. The scale of this, the intensity of it, and the duration of it, I think, were all things that I know some folks probably could have imagined, but most of us could not have imagined something of this scale and this duration, and the impact that it would just have on society, just absolutely disrupting so much of our commerce and our lives. It's been exhausting, to be sure. I think for everyone in different ways. The public is certainly tired of this. We as health professionals are tired to the bone, I think, of just both the level of effort, again, the long duration, and just the kind of extraordinary pressures that we've been working under in healthcare and public health. And I think the word traumatizing also applies to us professionally, to many of our patients and families and communities. Children, we know, have suffered terribly throughout this pandemic. And I think the impact on so many people is going to just take a long time to unpack and understand the layers of impact of this experience. But I know that for frontline caregivers, for folks who've been in the ICUs, who've been caring for a lot of COVID patients, watching so much suffering and death, and for everyone in healthcare who's been sort of affected by just the extraordinary pressures on the system, the need to be working in unfamiliar ways, supporting colleagues, and certainly we in public health, just that so many levels of pressure that I think the word trauma is fair to apply to what a lot of us have been through and frankly continue to go through. This is a weird time, frankly. The public is clearly ready to move on, if it hasn't already moved on, and to put the pandemic in the rear view. And we know that it is very much still with us. Certainly for people at higher risk, I think there's some building resentment that people at higher risk for COVID feel abandoned by policymakers and the system, for the desire to just return to life as it was before, as if all is well now. And in fact, there are people for whom that is far from true, including many in healthcare and public health, of course. Another word certainly that comes to mind is polarizing. And that I think is part of what's fueled the trauma for many. Just the degree to which a public health emergency, which typically one would hope and expect would really bring people together, has done quite the reverse. And instead of respect for science and for the people who are working so hard to save lives individually and at the broader population level, we've seen, certainly not from everyone, but significant pockets of the very opposite of that. Healthcare and public health people becoming villainized and accused by many of somehow fabricating if not the disease itself, the severity of it, the numbers. I can't tell you the number of questions and really admonitions that we've had at the health department, that I've had from many quarters, legislators included, about not trusting the numbers, and as though we would have some interest in inflating the numbers of cases or hospitalizations or deaths. And just the denial of the reality of the disease and the severity of the disease that has been with us since the beginning and persists today has been just something hard to get our heads around. That rather than being kind of a source of objectivity and truth, when it comes to health advice, we've become viewed with skepticism and outright hostility by certainly it's a minority of the population, but a fairly vociferous and sometimes pretty scary minority. I think this pandemic has also been revealing, not so much maybe that the issues are brand new, but that some of the systemic challenges that we've dealt with in health and healthcare have been just put into even more stark relief by the pandemic. And we'll talk about that in a little bit more detail. But in addition to those kinds of words about the sort of the difficult and harmful and negative impacts of what the pandemic has been and frankly still is in many regards, there are also some other words that come to mind, or thoughts that come to mind, and one certainly has to be just the triumphs of science that we've seen over these last couple of years. The speed with which knowledge has improved and been shared around the state, certainly around the country, around the world, the development of the vaccines in record time, the continued advance in that technology and in the development of therapeutics, rapid adjustments that have been necessitated by the incessant and rapid number of mutations that we're seeing in the virus itself, that necessitate science always needing to continue to try to evolve as fast as the virus itself is evolving. Also, I think innovation and adaptation are hallmarks of what these last couple of years have been. In care delivery, certainly, of necessity, finding new models, new ways to deliver care, the virtual explosion of tele-everything, telehealth, certainly, and the promise that has for improving access to care, especially for some populations that have had a harder time having in-person access to healthcare when most needed. Not that telehealth replaces in-person care, but certainly can augment it. And I've certainly benefited from quite a bit of telehealth recently, and have appreciated the speed and the convenience of that. The adaptability, again, that folks have shown in changing the way they work. Just how even platforms like this, how possible it is now to do things like having hybrid meetings that allow a lot more people to participate than might otherwise have. It's changing the face of work for a lot of people, certainly in some pretty remarkable ways that would have been hard to imagine. Just the sheer magnitude of the change we've seen in the way people are working over a pretty brief period of time. I think another thing, and I really especially want to call out Minnesota in this regard, I think just extraordinary collaboration that we have seen, certainly within the healthcare sector, our largest 9 or 10 health systems in Minnesota, who collectively represent over 90% of the care, have really, perhaps you've observed this yourself with your clinical partners, both at the clinical level and the operational and policy levels. Just extraordinary collaboration has been going on among the healthcare systems to share knowledge, to share resources, to problem solve, to work closely with us at the state to try to mount the most effective response that we could. And I think our degree of collaboration here in Minnesota, which certainly is historically something we're proud of through things like the Institute for Clinical Systems Improvement, ICSI, Minnesota Community Measurement, and all of the Minnesota Alliance for Patient Safety, all of those kinds of enterprises that we have built together over the years, I think have served us well. But we need more of it. Frankly, I hope that we can build on this spirit of collaboration to tackle some of the challenges that we are left with and the challenges that have deepened through the pandemic. And of course, just at the level of what so many people have given during this time. Again, specifically for our purposes this morning, calling out healthcare workers all across the healthcare continuum, but certainly we know teachers, frontline workers, public safety, so many people have just gone above and beyond. But just the sheer kind of professionalism, the dedication, the timeless, just the timeless effort that folks have put in is to keep going, sort of when the tank is completely empty, to just keep going to serve patients and communities has been remarkable and inspiring to see the level of dedication that our health community has had to patients and communities in our state. I think we are left with some very big questions with all of this. What are we going to take away? What are we going to learn from this? What are we going to decide to change as a result of this experience? And will we improve? Will we be more ready for the next health emergency? Will we be better able to serve all the needs of our communities going forward? I want to dig in just a little bit to a couple of these themes. First, around the devastation. Both, first in terms of just the health impacts of the pandemic. I know you probably know these statistics, but it really is pretty shocking when you get your head around this. We've now had in 2020 and 2021, the largest sustained decrease over 2 years of average life expectancy lost in the United States in 2020 and 2021. That's really stunning. That's the first continuous drop in average life expectancy of this scale that we've seen in the last 100 years. Just really, really kind of stunning when you think about that. At the whole population level, 2 years of average life expectancy lost. And in 2021, that really didn't need to happen. And it didn't happen in every country. Some countries saw, significant life expectancy loss in 2020, but then stabilized or even rebounded a bit in 2021. We did not in the U.S. I think for many, many reasons, certainly related to just the kind of the size and the diversity of our country. Not only demographically, but perhaps as important politically, just the fact that we had 50 different responses to the pandemic, or more than that, at the state level. And it's one thing I would dare bet my life savings on is that it is just not possible to manage a pandemic at the state level, or I would argue even at the national level. The world is too interconnected. And you can't put a giant bell jar over a city or a state or a country and not be affected by the disjointed policy coming either from the federal or level or what's going on in neighboring geographies. So I think that average life expectancy loss, another measure that will be interesting to track over time, is this notion of excess mortality. How much added mortality was there over what would be expected, just based on historical averages and population makeup. We'll learn more about that in the coming years, which will, I think, be a good way of capturing not only the direct impacts of COVID, but the secondary impacts as well. But again, just the sheer scale of the loss of life is really sobering. Over 1 million people in the U.S., over 13,000 people in Minnesota that we know of, that that sort of have COVID as a cause of death, kind of documented by the clinicians providing the care, and we go pretty deep into looking at each reported death with a mortality review team of epidemiologists that look pretty closely at each death to see if it was in fact attributable to COVID. So I really do take pretty great umbrage at suggestions that we're just making up numbers. I think we probably have in some ways a more thorough and more conservative approach to verifying COVID-related deaths than many. And that's just sort of a side note, but I would note one of the real problems, I think, in evaluating how we've done as a nation and as states in managing COVID is just we don't have very good data, frankly. The data, the definitions of what constitutes a case, what constitutes a death, how different states are counting deaths. Early on, you might remember, so much of the disease burden and the mortality burden was among the elderly in long-term care facilities. Total lack of standardization in how states would count deaths. Some states only counted where the death actually occurred. Other states, including Minnesota, counted where the person resided, not where they died. So we counted everything as a long-term care death when the person was residing in long-term care, even if, and many of them did, most of them probably died actually in the hospital. Other states would call that a hospital death, not a long-term care death. So that's a kind of a side point, but an important one, that our data has really been shockingly poor and inconsistent in terms of how we measure, really critical things. But just again, in addition to the clear loss of life and the huge disparities and inequities that we've seen, and when you look at severity of disease particularly on an age-adjusted basis, we see the burden of morbidity and mortality being multiples higher in some of our populations. American Indians, Black Americans, in particular, Latinx, and just that, those disparities that I know you folks are looking closely at too. With those disparities have been here for a long time, but the pandemic certainly just exacerbated them. In addition to the lives lost, the devastation, the impact of the people left behind, and you might have seen just recently some studies out estimating that over 10 million children in the United States lost a parent or a primary caregiver to the pandemic. That's pretty stunning statistic as well. And even though we've been in this strange kind of period over the last several months now of things feeling pretty stable in terms of number of COVID cases and hospitalizations and deaths, we've not been going up, nor have we been going down, really. We're still both as a country and as a state. We have a lot of virus, a lot of people ill every day, a lot of people in the hospital, 400, 500 a day in the hospital. At the national level, still about 400 people a day have been dying, much less than the peak of the pandemic, but still 400 people a day. That makes COVID still the fourth leading cause of death in the nation, which again is just such a big disconnect with where the public is in terms of this no longer being perceived as a big issue or a threat. Also, I think the devastation, I think, again, will continue to, to unfold over, I'm afraid, many, many years. But we're just beginning to understand what long COVID might mean in terms of ongoing health burden, as well as increases in other conditions that we've seen during this time. Literally, probably almost every chronic condition that you can think of has been affected and probably worsened by the pandemic due to both the secondary health effects, but also foregone care, folks not getting screened, diseases not being managed as well as is optimal. And I think we're just going to see, we already are seeing the rise in both incidence and severity of conditions. And certainly that's part of the phenomenon of what's going on in our hospitals now. We're very full, as I'm sure you know better than anyone, in our healthcare system. And, again, with 400, 500 people a day in the hospital with COVID, that's not trivial. But the people who are in the hospital for other conditions are also more severely ill than they typically have been, which is just creating a lot of pressure on the healthcare system's capacity. And certainly specific things like mental health, substance abuse disorders, that we've seen significant rises in those numbers, as I think secondary effects of the COVID pandemic. And we've seen, certainly with all of the furor around misinformation and flat out disinformation about the impact of immunizations, we're seeing that spillover effect in other vaccine preventable diseases. Very concerned about what that will mean for the health not only of children, but especially of children in the near and medium terms here going forward. And also, beyond the direct impacts that we can measure on health, the larger impacts, which we know also profoundly affect health from a social and economic determinants perspective. Just the changes in the economy, the job losses, the losses of investments and economic security for many who had the least safety net to begin with. Those all have health consequences, as well as the educational loss that our children have experienced over these last couple of years. Profound impacts, and one of the real tragic impacts of COVID has been the disruption to children's education, and that we know has its own immediate and longer term health effects as well. So that's a litany of all the ways in which the pandemic has been and continues to be really damaging. And again, it's kind of blows my mind the degree to which there's a sort of a disconnect between how impactful this has been and continues to be with sort of the kind of our collective understanding of it or our attitude about it. I mentioned some of what has been revealed, or perhaps better said, further illuminated by the pandemic around the inequities, the disparities that we've seen, both the disproportionate risk of infection, of exposure in some populations, driven by people's occupations, their living conditions, their housing, their benefits or lack of benefits when it comes to health insurance, paid time off, ability to isolate and quarantine or not, and all that has meant to people's risk of exposure, but also then their risk of worse outcomes when infected, due to lack of access to testing, vaccinations, treatments. And then, of course, even without those barriers, even for people with benefits, we know that the systematic and systemic kind of barriers to access and inequities and outcomes have persisted across the pandemic as well. Another thing I think that's been just further illuminated, if we needed another reminder of how fragmented our healthcare system is. This has certainly shown that, again, how fragmented it is, despite how absolutely interdependent all parts of the continuum are on each other. Thinking specifically here about the relationship between acute care and long-term care or post-acute care. We know, just have heard from many medical leaders and health system leaders, that large numbers of people in the hospital every day who really don't need to be in the hospital, but they can't be discharged because there's no place to discharge them to in terms of rehabilitation facilities, skilled nursing, or mental health facilities. So folks are stuck in the hospital, which is already stressed for capacity because of the workforce shortages and the capacity constraints in other parts of the health system. Also true, I think, but in the relationship between clinical care and public health, in terms of some of the discontinuities there and the misaligned incentives and the unclarity, I think, of roles. To me, that's one of the really big takeaways here that we really need to spend some time talking about and thinking about, is what is the role of various pieces of the system in a public health emergency, and really to manage population health overall, but especially in a public health emergency like this. It's just really not that clear. Whose job is it to make sure that there's an adequate level of testing, of vaccination, of therapeutics? In our, particular system of health insurance that provides the doorway to healthcare for most people, we know there's just so much variability there. And I think it's going to be really interesting, and it's starting already, but it's really going to accelerate in the coming months and next year as the federal government transitions away from this extraordinary kind of publicly financed response to the pandemic back to these various products, therapeutics, immunizations, testing being left to the commercial market, not paid for by the government anymore. It's already happened with the one monoclonal that we have that's effective against the Omicron variants, that's bebtelovimab, that's now commercialized. So it's not being paid for anymore by the government, with the exception of some programs that are trying to still leave a safety net for uninsured and underinsured. But as that is going to happen with vaccines, it's going to happen with other therapeutics, oral antivirals. It's very much happening with testing already, as the feds are getting out of the business of providing free tests. As that transition happens, I think it's going to be really interesting to see how does the public react to that, having been used to, for the last couple of years, a very different model of access to at least those kinds of services, and the kind of the sticker shock that's going to happen when people have to pay for the tests and the therapeutics themselves. We hope that vaccines will be, continue to be funded by the government in a more robust way, as they are for childhood vaccines, for example, and vaccines under Medicare, for example. So hopefully that will continue. But just this is going to be a pretty big shift and a pretty interesting phenomenon to see how the public reacts to going back to this really patchwork quilt system of who has access to what and who is providing what, and how hard is it or easy is it to get these things that are actually quite important to managing a pandemic, for example. I think that's really, and again, just thinking this through, thinking about what should be the financing mechanisms and how do we build up the capacity in the right places to do more of this and more of that during a public health emergency. Because right now, frankly, our capacities and our financing, our incentives are not aligned at all about really who is in the best position to do what. Lots to think about and learn about there. But I want to sort of end on what there is to just kind of celebrate and build on. And I think I've alluded to this earlier, but just with the rapid advances in science, how do we keep that going? How do we foster that spirit of innovation and that kind of open sharing of knowledge? How to, we've been trying to do that. Health systems have been leading on that, developing best practices, trying to share best practices. But we know, how far we still are away from having, more standardization around evidence-based best practices in our healthcare system overall. How do we build on that collaboration among health systems and across healthcare and public health, and really figure out how to maximize the capabilities of each? Healthcare, I think, for acute care is very dependent on long-term care and vice versa. Long-term care needs hospitals to be able to take transfers from people who are sick. And healthcare is very dependent on public health being able to do its job to help manage outbreaks and keep people out of the hospital. And all these things need a systemic kind of look and attention. If we want these various parts of the interconnected system to be better connected, how do we better connect the information? How do we better align the incentives? And how do we get more clarity about who's going to do what going forward? I think there's just much to learn here. Another good example of collaboration that I hope we can and will build on is the Electronic Health Records Consortium, which has been just an invaluable partner to us at MDH in collecting better data to inform our response. And there's much deeper that we need to go in terms of disaggregating the data and really digging in to see where are the opportunities for greatest improvement. And I think we've learned, again, in these last couple of years, we can do things at scale quickly if we are focused on it and if we put the resources behind it. Just a very different approach than what we sort of typically have done in healthcare finance and healthcare delivery and public health delivery. Public health needs a lot of change too. I'm not just asking and pleading with the healthcare system to do that kind of introspection and improvement work, but we in public health need to do that as well. And I think you've probably read about, sort of some of the changes going on at the CDC and the introspection there about what didn't go the way it could have and should have and needs to. That's, I think, necessary and appropriate. Here in Minnesota, where we've been engaged for the last several years, but this really has redoubled the urgency, really having some deep conversations about how the public health system is built. What are the relationships and the best, the most optimized relationships between local public health agencies and the state, between, again, the private sector, healthcare delivery partners, health community-based organizations, and governmental public health. And all of those things need a close look and are very due, I think, and overdue for kind of modernization. And how do we apply technology smarter and better to some of the, particularly given the workforce challenges that we face that are just pervasive everywhere. So with that, I just want to close with a thanks to all of you for your work, not only during the pandemic, but every day, everything that you do to serve your patients, to serve the community, and particularly from the perspective of the foundation, to advance science and to advance best practices. The work that you do is critical every day, and certainly urgent in these times. So with that, let me close and hopefully open it up for some discussion. Thank you again for the invitation.
Thank you, Commissioner Malcolm. That was incredible. Always so much to learn from you. I alone could probably spend the next 20 minutes asking you questions, but I'll turn to my colleagues here and open it up for questions.
Thank you very much, Commissioner Malcolm, for speaking with us this morning. Fantastic discussion. And I just wanted, I noticed how you talk a lot about kind of forward thinking. So I have a forward thinking question for you. It's my impression that our access to care is broken and our delivery model is archaic. Is there a role the state can play in helping us to transform how we deliver care, how we more affordably deliver care? We're already seeing our health systems financially broken. Alina, they say down 100 million already this year. I just think a lot of it rests in how we deliver our care. Any thoughts?
Absolutely, Dr. Hurl. You're so right. I think it's all about the incentives, frankly, and the financing system. And not that that's going to fix everything automatically, but it's sure hard to improve care delivery without the incentives being in the right place and the investments being in the right place in the system. How do we build up more of the kind of capacity that we need, to prevent and manage chronic conditions, for example, and not just, treat everything as episodically as we do in financing and delivery. So yeah, I think, we haven't really, had a very robust conversation about how the healthcare delivery system itself can best be supported. Now we've got this massive workforce challenge. We have significant financial challenges inside the healthcare system, as you point out. But all in air quotes that we've really been thinking about and debating at the national level or the state level in the last couple of decades, frankly, is insurance, which is important, but not by far not adequate to understanding how how care is actually delivered and paid for. And in the insurance system, like you said, access is pretty broken. We have, I don't know if you know this, but this really was not a bragging point, I think, for Minnesota. We actually lead the nation in the highest out-of-pocket healthcare costs for the insured population. Wow. We've got a lot of people insured, but the shift in recent times has been, or not so recent times, over really 20, 30 years, has been shifts to higher deductible insurance products, higher copays, so that, we're kind of back to that insurance being kind of a financial safety net, but not a great way to finance, access to primary and preventive and chronic disease management. So I think we have to have a more robust conversation about the role of public policy and public financing in supporting and rebuilding the kind of system that we need. At least 2/3, probably more, of the money in the healthcare system is public, which is ironic because we so pride ourselves on, thank God we, have a private sector healthcare system. Yes, in many regards, but a lot of the financing is in fact public and not very smartly allocated from that perspective. So I hope again, this sort of, if people have their heads around the magnitude of this challenge and the fact that this isn't the last time we're going to be confronted with a challenge that is global in scale. How do we build a system that's ready for that and able to deliver higher value care every day? Hopefully this should be a wake-up call for policymakers and health leaders, public health leaders to sit down at the table and reopen some of these bigger systemic conversations.
Other questions?
I see one question in the Q&A from Dr. Olson or Mr. Olson. How long do you think we'll be masking in healthcare facilities? It's a really interesting question. I think I think the the reasons to mask in higher risk environments, long-term care and acute care, congregate settings, that clearly there's a different set of circumstances that would lead to masking making sense. I actually had a chance to be an inpatient right down the street not too long ago, and one of the folks who was caring for me, we were having a conversation about this very issue, and that provider said, "I don't know why we haven't always worn masks more often than we do outside of the operating room." So I'm sure opinion is widely mixed on the importance of masking inside the facilities. But I think we'll sort of see to what degree the CDC guidance evolves when it comes to healthcare facilities or doesn't. I mean, they've been pretty, holding the line on needing to still have a higher standard of protection in some of these facilities. But I'm sure that'll be a vigorous conversation, internally within health systems as well. I myself am planning to wear masks in the winters for forever. It's kind of been a good thing that we've seen less of other respiratory illnesses too these last couple of years. Certainly, we've had a respite from the impact of flu for these last couple of years that we're not expecting to see continue, given the lack of those kind of community mitigations. Sorry for that long-winded answer, and probably not very satisfying one.
Thank you for being with us this morning. And I hate to ask a question when you're not feeling well, but what would you do differently looking back over the past 2 years?
Yeah, thank you. I think there's a ton to look at. I think, one thing, even though we knew about health disparities, we knew about, kind of disproportionate risks. I don't think we were as focused early on in the pandemic as we could have been, or arguably should have been, on making sure that the most vulnerable populations had that extra support to get access that was needed. I think we've gotten better as time has gone along, in part due to better data and holding ourselves to a higher standard of what we should be measuring. But I do think, kind of calibrating the response to the levels of risk better would be one thing. And certainly, it's always, Monday morning quarterbacking is to be expected and fair in some regards, but it also kind of bears reminding folks that this is still a 2+ year old phenomenon that we've learned a lot about. But at the beginning, especially, there was so much we didn't know, and so much we got wrong about basic assumptions about transmission, for example. That, had we known then what we know now, would have done a lot of things different, and we would have been smarter about masking and about kind of concentration of risk. I think we should have a debate about schools. I think the data have been really mixed all along about the impact of COVID on not only on kids, but the role of schools and the role of kids in community transmission. So just kind of having better information to look at some of those things that are far from black and white. Every decision has been, agonizing in a certain senses about the pros and the cons and the risks and the benefits. But I think better data, again, across the systems would have helped us be smarter, faster. And I hope we will fix that. The flow of information within public health, from the feds to the states to the locals, the sharing of information between healthcare and public health has just not been what it needs to be. So I hope we will fix that going forward.
Thank you, Commissioner. This is a question. COVID seemed to expose this challenge of transitional care capacity. And I can't tell you how many times I heard we can't get patients in because we can't get patients out.
Yep.
And I'm just curious if that happened on a national level like it did here. And then should that be something that states or nationally we're looking at to make sure we have the right levels when this happens again, because it probably will happen again, that we're ready for that.
Absolutely. Yeah, it is a national phenomenon, and it's been building for some time. And we've had workforce challenges in long-term care, much sooner and to a much deeper degree in long-term care than we have in acute care. Now we've got a workforce crisis is perhaps not too strong of a word, certainly big challenge in acute care as well. But it's really been building for years and years and years in long-term care. And partly that's again due to financing. Jobs in long-term care are not very well paid, and they're predominantly publicly financed. Yet it's very hard to get Congress or legislatures to say, oh yes, let's spend more of the Medicaid budget on paying more for long-term care. So that too needs new design of care models and a different level of collaboration between long-term care and acute care, I think, to make those transitions of care easier. We are, very much trying to think through and work with long-term care and hospitals right now on what will be our better strategies for future surges of this pandemic or the next ones to come, on how to make some of those transitions of care easier. How do we position some facilities to get extra support when it comes to staffing or technology or clinical support, to be able to take the higher level of care needs, but also the higher volumes that we would expect. So I think we're working on some things right now, but again, it's back to that bigger picture. How should we finance these critical systems so that they've got more resiliency and more surge capacity? Because right now everything is just running just in time and really lean and really just doesn't have much capacity to flex when needed.
I have a question for you, Commissioner. I heard the Surgeon General say recently that, social isolation really is our next epidemic, and particularly after the pandemic, that the equivalent impact of social isolation is the equivalent of 15 cigarettes a day, which I think really, as a cardiology crew here, puts things into perspective. How do you balance all of this? You mentioned some of the impacts we're seeing mental health wise, but just in sort of our individualist society. And I think we're seeing that in our patients as well, folks who are afraid to congregate again, in particular, some of the more vulnerable populations, which then again, I think leads to these bigger disparities at the population level.
Absolutely. Yeah, I think, I mean, isolation has been a problem, but it certainly has been exacerbated. And again, I think it's part of the challenge is how do we make it safer for vulnerable populations to not be isolated? And that's just a really vexing problem. I mean, I have heard just heartbreaking story. I mentioned the Minnesota Alliance for Patient Safety earlier on, heartbreaking stories from families about the impact, for example, on no visitation policies in hospitals as well as long-term care, and the devastating impact that's had on patients and families, and understandably. And one understands why those no visitation policies were there and were thought to be, so important to prevent transmission. It's just an example of there's not an obvious right or wrong or easy answer here. So just even within the realm of healthcare, how do we support? How do we deal with isolation, even among in the services that we're directly delivering? But that broader societal thing is really, I mean, wow, yeah. I mean, given the rise of kind of social media and technology, and watching our kids and ourselves being heads down in in the devices more than heads up talking to each other. I think it's this big societal challenge. And again, I just think we should be talking about the last couple of years and what it's done to us more than we are now, rather than just like, oh, thank God that's over, let's move on. I think really looking at what kind of not only what kind of systems do we need for better resiliency in the future, but how do we want to change the way we are? I mean, I know that's like hopelessly vague and imprecise, but at some really fundamental level, there's a lot here about kind of societal values as well.
Other questions? Yeah, go ahead, John.
Commissioner Malcolm, there's just a couple of questions online. The next question being, have we improved the process on assuring we have adequate supplies and internal manufacturing, i.e. not relying on other countries to be able to respond to the next crisis? They go on to say that the contrast shortage was a good representation of that. So how can we move away from the all eggs in one basket approach?
Great question. And here's where I think it's troubling to see kind of the lack of policy discussion on this. One of the things that came as a nasty surprise early in the pandemic was the discovery that, there really wasn't much in the strategic national stockpile, and that the feds were not going to be the ones to solve some of these supply challenges, and the states were literally left to fend for ourselves and to compete with each other. It was crazy, and just again, not a way to manage a pandemic. So one of the things one would think that should happen is the rebuilding of a robust strategic stockpile and a real look at critical supply chains for exactly the reason that you said. And that was part of President Biden's budget proposal. I think initially it was $50 or $60 billion for investments in, both in the near term for ongoing pandemic response, but then also what are going to have to be the infrastructure, the ongoing permanent infrastructure investments in things like the healthcare workforce, the public health capacity, surveillance systems, supply chains. And so far, there's been not one new nickel appropriated for ongoing response, much less future preparedness. And lots of debates about, well, don't you still have some money? Or, well, you didn't spend the money very well, so we're not going to give you any more. So I think we need to, and here's where I hope the health leadership, can be helpful to both our state legislature and Congress people to understand, these are things that need to be fixed, as your questions have said, and kind of my takeaway as well. It's like, shame on us if we don't figure out what we should take away from this and how to prepare, because this is not a 1 in 100 year phenomenon anymore, I don't believe. So good question. I think it has to be federal. There's no way I think that the states should be in the business of trying to figure this all out ourselves 50 different ways or 57 different ways when you add in the territories. So I absolutely think your question is like a perfect example of where we need a much more robust national strategy than we have had or have at this moment.
One last one, I think.
Yes, thank you so much, Commissioner Malcolm, and that makes a ton of sense. Certainly a complex issue. So this may be a good question to end on, and that question is, in your estimation, what are the next best steps moving forward?
Well, I mean, I do hope, as busy as everyone is and exhausted as everyone is, that we can take some thoughtful time to debrief and to share perspectives, to sit down at the same table and say, I've just laid out a bunch of what's top of mind for us in public health, but what's top of mind for you guys? And again, as we're hopefully teeing up the need for some of these broader systemic fixes, how do we do that, collaboratively? I think all of our voices together would be more, I hope, more helpful and have a larger impact on our policymakers, whether that's the state legislature, the state executive branch, and federal. Again, I'm just going to keep saying, I think there is, while the diversity of state approaches is good in many ways, it is like the worst thing in the world when it comes to trying to manage a large public health emergency. So figuring out how to build more political will for a smarter kind of national strategy and response is really urgent, I think. I know we're at time. I thank you for your attention and again, for the great work you all do every day. And thank you
so
for
much,
your
Commissioner.